out, or two of them go out, you move abnormally, too much movement or too little movement. This is a picture of what's called a synapse. The presynaptic one is the cell that's connecting to the postsynaptic cell, and this is where dopamine is made. If I could get this pointer up. Well, anyway, when you take dopamine, it actually goes across the blood-brain barrier into the cell, and the cell manufactures what you take, L-dopa, into dopamine itself. It's been stored in these little vesicles and released through those green channels, and then it hits the postsynaptic cell at the receptor. That sends the signal to that cell to go to the next cell, and so on, eventually down to the muscle. But we think that probably Parkinson's disease is a combination of things, not just one abnormality with the dopaminergic cells. In other words, we think probably you have abnormal protein accumulation in your brain. Something goes wrong at the level of the mitochondria, which is the energy powerhouse of the cell. You couple that with a little bit of genetic influence, maybe some free oxygen radicals, and that leads eventually to cell death. So how does your doctor diagnose Parkinson's disease? Well, this is still what we call a clinical diagnosis. In other words, the doctor makes that diagnosis by listening and looking at you. Sometimes the doctor uses your response to an anti-Parkinsonian drug to see if you respond to it. That makes them feel better that they have the right diagnosis. Other doctors don't do that. But you don't find Parkinson's on a blood test. You don't find it on a brain scan. If your doctor orders that, they're usually doing it to rule out other conditions such as normal pressure hydrocephalus, water on the brain, multiple strokes, a brain tumor, B12 deficiency that can mimic Parkinson's disease, but they're not doing it to diagnose Parkinson's disease. Sometimes I use a fluorodopa PET scan in cases that are difficult to figure out, but it's not a routine use. And if it's negative, that doesn't mean you don't have Parkinson's disease. The doctor also uses something called red flags or exclusionary criteria. If you have early autonomic involvement, that usually means you don't have Parkinson's disease, but you might have one of those other disorders that presents with that. What is the autonomic system? That's the system that regulates the internal environment of your body, like temperature, blood pressure, bowel movement, sexual function. That often does get affected in Parkinson's disease, but fairly late. If you fall a lot early on in the diagnosis, your doctor might think you have a condition called PSP rather than Parkinson's disease. Early dementia is uncommon in Parkinson's disease. That's more common in other disorders that mimic Parkinson's, like Lewy body dementia. If you don't respond to high doses of levodopa, makes it much less likely that you have idiopathic Parkinson's disease, although about 10% don't. Rapid progression is unusual in Parkinson's disease. That might indicate that you've got more of a dystonia disorder, genetic dystonia disorder. Difficulty looking up or down is more common again of a different Parkinsonian disorder. And if you have Parkinson's only in your legs, that means you might have more of a cerebral vascular problem like strokes rather than Parkinson's disease. So your doctor should be familiar with all of this. Most movement disorder Parkinson's doctors or neurologists are, and we'll use that as part of diagnostic criteria. So who gets Parkinson's? Well, you're in, let's say, not good necessarily, but illustrious company. Salvador Dali had Parkinson's. Hitler had Parkinson's. John Paul II, Michael J. Fox, Janet Reno, Muhammad Ali. And there's been a lot of speculation as to why these infamous or famous people get it. It could be because there's a Faustian bargain, fame first, then I'll give you Parkinson's disease. But most people think that actually Parkinson's disease people, because of their personality types, are prone to success. So that some of these traits that Parkinson's people have lead them to be very successful or famous people. I'm sure you've all got those traits. It's fairly uniform, and I'll go over those a little bit longer. Parkinson's disease can occur at any age. I think Michael J. Fox was 29 when he first developed his symptoms. Is there a Parkinsonian personality? Well, a lot of Parkinson's people tend to be rigid, a little obsessive or OCD, anal as they call it, sometimes introverted, nervous, cautious, very intelligent usually, and this combination of traits usually leads to a high degree of success in life. But it also, the cautiousness and nervousness about things leads Parkinson's people to, they usually don't smoke, they usually don't drink heavily, and they usually don't imbibe caffeine or coffee a lot, which leads to this idea that maybe those things are protective in Parkinson's, but I think it's just that Parkinson's people's personalities don't allow them to indulge in lascivious behaviors. For instance, you rarely see an obese Parkinson's patient. It's very unusual. Most Parkinson's people tend to be on the thin side because they don't let themselves indulge in a double Whopper every night. Very interesting. So how does Parkinson's disease progress? That's what everyone always wants to know. There's kind of two areas you need to realize. How does it progress if you don't take medication? How does it progress if you do take medication? And how does medication itself mitigate or affect progression? Do the medicines that we have currently available for Parkinson's disease actually slow it down? Well, we have very, very limited data on any drug that actually significantly slows the disease process. Although some of the MAO-B inhibitors, some of the dopamine agonists do have some data that it may slow progression a little bit. The study designs have to be very, very carefully designed to try to prove that. Do the medications in and of themselves cause complications? Yes, indeed they do, especially levodopa. That's the big gun drug, Sinemet.